Okay, it's my pleasure to start and introduce myself. I'm Lidia Rudnicka, I'm from Warsaw, Poland, and I have been a dermatologist for a quite long time. And every time I see a patient like this, I feel that I may have a problem because topical steroids may not work. Systemic steroids, they do not give permanent efficacy, so after a while, I may have a patient with alopecia areata and the adverse effects from corticosteroids. Cyclosporin leaflet is saying we should not use it below the age of 18, and methotrexate has controversial efficacy. So we all were hoping for some new drugs to come, especially that whatever we were doing was off-label. Well, now we do have ritlecitinib, and the title of my lecture is A New Hope for Patients, but I think it is also a new hope for doctors. And I may even say that in our clinic, it moved from being a hope to being everyday practice. Ritlecitinib is a JAK inhibitor, or maybe more precisely, a kinase inhibitor. It is selective. It inhibits one molecule, but because this one molecule is present on two different kinases, it will inhibit two different kinases, what is important for the efficacy. And it is approved from the age of 12 and for adults, and it is approved for severe alopecia areata. Now, what means severe alopecia areata? Severe alopecia areata, when we take a look at the normal or typical progress of the disease in alopecia areata, up to alopecia totalis and universalis, which affects up to 20% of patients, then we measure the severity by the percentage of scalp hair loss. And when we take a look at the possibilities, if the patient has a loss of less than 20 or 20% of scalp hair, we say it is mild form of alopecia areata. Then it is moderate, and if it's 50 or more, we say it is severe. Now, in a recent consensus that we have published, we indicated that patients with moderate to severe alopecia areata should receive systemic therapy. The approved indication is 50%, meaning the severe alopecia areata. And we have now two JAK inhibitors that we can use. In children, only one of them, ritlecitinib. The other one is only for adults. And when looking at this, ritlecitinib, and this is the topic of my presentation today, ritlecitinib went through multiple clinical trials, and I will make a very short summary of the data because I know that doctors prefer to read summaries and conclusions. So this was a clinical trial with a placebo-controlled part or phase and a non-placebo extension phase. There were various doses that were evaluated, and the final dose that was picked for registration and finally approved was the dose of 50 milligram. So the dose that is approved now is 50 milligram, one 50 milligram tablet per day. And in this study, patients who were SALT 50 to 100 were evaluated, and this is why some of the insurance companies, at least in our country, prefer to not reimburse the treatment below the SALT score of 50. I know that you have here a wider possibility of reimbursement. Now let's look at the efficacy. When we take a look at the efficacy and compare it to placebo, ritlecitinib, after 24 weeks, it was 23 to 31%. It was significantly higher after 48 weeks, and we know from the data which were shown at conferences that if you keep the patient longer on the treatment, then even the number is increasing. So the efficacy of ritlecitinib, and this is true for all JAK inhibitors, it is increasing over time. In alopecia areata, it's a little bit different compared to atopic dermatitis. In atopic dermatitis, You treat the patient with the JAK inhibitor today, and he has an improvement tomorrow. In alopecia areata, we need to be patient. When looking at the data from adolescents, they're quite similar to the adults, and the numbers are very comparable. However, also I would like to draw your attention that the placebo number is 0 in the control group. The number of responders is 0. So definitely a justified hope for the patient. So basically, there's no significant difference, at least according to the clinical trial. There's no significant difference between the response in children and in adults, despite the fact that we may suspect, without knowledge of the data, that maybe the children should respond better. Interestingly, the patients are more satisfied with the treatment than the doctors. So the satisfaction rate is 64 to 75%. Few words about the eyebrows and the eyelashes, which I think is important, and I will tell you in a moment why I think so. The numbers are higher compared to the numbers for the scalp. And we will understand why in a moment. I would like to show you a case from our clinic, from our practice. This is a young man who had alopecia areata for several years. He did not respond to anything, to steroids, to cyclosporine, to methotrexate, and many other attempts were made. And finally, we were able to give him ritlecitinib, and this is the baseline. You see some black dots and some exclamation mark hairs. Then, after several months, some black dots, no more exclamation mark hairs. After 9 months, only yellow dots, so no black dots. We were a little bit unsatisfied at this moment. However, we need to keep in mind that black dots and exclamation mark hairs are markers of disease activity. So the markers of the disease activity were gone, but we had no hair regrowth. And then after 12 months, we have seen a regrowth of eyebrows, some regrowth of the eyelashes, and a significant regrowth of the beard area. And what is interesting, and this is observation in all our patients or almost all our patients, that the regrowth in alopecia areata, in patients with alopecia areata treated with JAK inhibitors, starts usually with the eyebrows and the eyelashes, and in men, it starts with the beard area. So this is always a good prognostic factor for the future. Why is it important? Because when you read the SPC, you will see the text: consideration should be given to discontinuing patients who show no evidence of therapeutic benefit after 36 weeks. This is approximately 9 months. Well, this was supposed to show that, unlike we were used earlier with corticosteroids or with cyclosporine, that if we see no effect after 6 months, then we discontinue. Here, we went further because of the way that ritlecitinib is working. However, now we know that maybe after 9 months, maybe we should still wait, and maybe this is the part of the SPC that may be changed in the future. Why? Because there are patients who are early responders. The early responders respond within half a year. But there are some patients, this is 10% of patients, who are late responders. They respond between month 12 and month 24. So they start a significant response after 1 year. So we need to be patient when treating patients with JAK inhibitors. There are two main determinants of treatment efficacy. One of them is the disease duration. The more years have passed since the last regrowth, the less likely the treatment efficacy for all treatments, not only for JAK inhibitors, and also the disease severity. The more severe the disease, the less likely the patient is to respond. And it has been shown for JAK inhibitors that if the patient has SALT 100, he is less likely to respond compared to patients who have a SALT which is lower. Now, the patients and their parents are always asking about the safety. And here we can say that regarding ritlecitinib, most treatment-related adverse events were transient, mild, and mild to moderate. And I will go through the most common adverse events very fast. This is the graph, and you will see on the left side the placebo, on the right side ritlecitinib. And for nasopharyngitis, for the infection, it was for the ritlecitinib, it was 9.9, slightly more compared to the placebo. Headache may be present slightly more commonly than in patients who receive placebo. Diarrhea is possible. Acne, we have seen patients who developed acne, not so much after ritlecitinib, but also we had one patient who had acne that became more severe after he started the ritlecitinib treatment. And this is acne, these are acne results, and urticaria is also possible, and allergic reaction that usually develops within the first year of treatment, if it develops. Some patients may develop vertigo. So this is a very short summary of all the possible common adverse effects. However, when looking at the multiple possible adverse events which are not so severe, but the number may seem quite high, what is interesting is that patients who discontinued treatment because of adverse events, here the number is very similar to placebo, maybe slightly higher compared to placebo. And one thing which I think is worth mentioning is that ritlecitinib is not on the INT'L list of JAK inhibitors that with recommended measures to minimize the serious side effects. As you know, the other JAK inhibitors, which are JAK1 inhibitors, because ritlecitinib is not the JAK1 inhibitor. The JAK1 inhibitors that are used in dermatology, that are on the list, and it is recommended they are not used in patients who smoke and patients who are 65 years old or older, and on several other occasions. So ritlecitinib is not on this INT'L list. And with this, I would like to come to conclusions. Ritlecitinib 50 milligram, or ritlecitinib in general, is the only EMA-approved treatment for adolescents with alopecia areata. It is also approved for adults. It is a selective JAK3/TEC inhibitor. It has a significant efficacy in clinical practice. And what is important to remember, that the patient and the doctor needs to be patient because the regrowth may take some time, usually several months. However, in our clinical practice, this is usually between 3 to 6 months before we see the first regrowth. And with this, I would like to invite you to the European Hair Research Society meeting and trichoscopy course that will take place in my hometown, in my home country, in this year in May. Thank you very much. If I can respond to any questions, I will be happy to do it. If not, I leave the floor for the next speaker. Thank you. No, for the break, I think for the break? Yeah?
No.
No, for the next speaker. So the next speaker is welcome. Thank you very much.